Good evening, sir.
Good evening.
Good evening.
Good evening, everyone.
Shall we start, sir?
Yes, yes.
Srikanth, good evening.
Good evening, sir.
A very good evening to everyone. I welcome all the members to this clinical pathological case discussion on epigastric mass. So we have Dr. Nishan Shetty, second year resident from Ramaiah Medical College, who will be presenting the case. And we have a moderator. This session is moderated by Dr. Shivaratsa MR, professor in the Department of General Surgery in Ramaiah Medical College. We have Dr. Rajiv Lochan, leading liver transplant surgeon, Manipal Hospital. And we have Dr. Mangala Gouri, Professor and HOD, Department of Pathology, Ramaiah Medical College. Before the start, I request our chairman, Dr. H.V. Shivaram, sir, to welcome the gathering.
Thank you. Thank you, Dr. Chandru. Good evening to everybody. I welcome you all who all have joined for this very important webinar. Clinico Pathological meeting or Clinico Pathological conference was a very important tool of teaching when we were students. But after the internet came and there is a lot of material available, this has come a little back to the teaching tool. But we just wanted to introduce it and also the students to have a look at it, how it helps in the teaching tool. It's a very dynamic tool of teaching. Actually, it was started by a Harvard internist at Boston, Dr. Richard Cobol. And it gives a lot to think for the students and also for the teachers, and finally leads to a logical conclusion with lot of differential diagnosis and finally coming down to few of them. So that way we have an excellent case and also excellent discussant, Professor Dr. M. Sreevathsa. We have pathologist, Dr. Mangala Madam, and we have the liver transplant surgeon, Dr. Rajiv Lochan, and also radiologist, Dr. Vinay Prabhu. Vinay, welcome to you. So with all these great teachers and also the audience, I welcome Professor Santosh Jan Abraham, Dr. Abhay Dalvi, and all the seniors who are all here. And let us get on to the CPC today. I hand over to Dr. Sreevathsa MR to conduct further proceedings. To you, Dr.
First of all, I am humbled by your words. Calling us great teachers.
Yes.
I hope so. So let me first thank the chairman, Dr. Shivaram, and the honorary secretary, Dr. Chandrashekar, allowing us to host this CPC on the platform of KSCASI. This presentation comes from, as you said, from the Department of Surgery, MS Ramaiah Medical College and Hospital. And the discussant, Dr. Nishan Shetty, is a bubbling, energetic, young enthusiast who is 4 or 5 months into the second year of his residency. And the model that we are going to follow today would be that he will give the history first, and he will have a list of differential diagnosis. He will give the pros and cons, or the positives and negatives for each diagnosis. And then he goes to the clinical examination. At the end of clinical examination, he's going to narrow down the differential diagnosis and give us reason as to why he eliminated 1 or 2 from the first list of differential diagnosis. And then comes the investigations, and then the diagnosis narrowed further, differential diagnosis narrowed further. And then finally the operative images, and then finally the final diagnosis rests on the pathologist. And as you have already said, we have the 3 panelists. I'm going to be the moderator. The 3 panelists are going to give their expert comments, including Dr. Vinay Prabhu. And I welcome all the guests, invitees, and the postgraduates. You are requested to put up your questions on the chat box, and Dr. Shivaram can convey them to us, and we'll be able to answer them. I just want to remind the listeners that this patient was, economically low and was managed in a highly subsidized manner in a setting of a medical college hospital. So over to Dr. Nishan Shetty to start the presentation.
Yes, sir. Thank you. Good evening, everyone.
Good evening.
Today I'll be presenting the case of a 40-year-old female who is a housemaid by occupation who hails from Yelahanka, Bangalore. She presented with the chief complaints of upper abdominal pain since 10 days and upper abdominal distension, which she noticed since the past 3 days. History of presenting illness. The upper abdominal pain was localized to the epigastrium, was dull aching in nature, was continuous and non-radiating. It aggravates on food intake and is relieved on taking oral analgesics. She also gives a history of upper abdominal distension, which she noticed since the past 3 days, which was localized to the upper abdomen and is non-progressive. For the above complaints, she visited her general practitioner and was then brought to the notice of an upper abdominal mass. There was no history of fever, nausea or vomiting, early satiety, jaundice, altered bowel habits, loss of weight and loss of appetite, episodes of pain abdomen in the past, and there was no history of oral contraceptive pill use. There is a history of a dog in the household since the past 6 months. Coming to the past history, she is a known case of hypothyroidism and has stopped medication 12 years ago. She underwent a laparoscopic tubectomy 3 years ago. Family history, there was nothing significant. Personal history, she consumes a mixed diet. Bowel and bladder habits are regular. There is no history of smoking or alcohol consumption. Her menstrual history, she attained menarche at the age of 15 with regular cycles, 3 to 4 days of bleeding in a 28 to 30 day cycle with normal flow. This is my provisional diagnosis after the history. At the top, I would like to consider hydrated disease of the liver, then a hemangioma of the liver, cystic neoplasm of the pancreas, hepatic adenoma, an amoebic liver abscess, an acute peripancreatic fluid collection, and other diagnoses such as a gist of the stomach.
Nishan, can you give us a few pointers in your history that you have used to make these diagnoses?
Yes.
Why did you make a diagnosis of each one of them? Quickly, can you tell us?
Yes, sir. So, hydrated disease of liver I've considered because she's presented with vague upper abdominal pain and a mass in the upper abdomen. With the yes, sir. She also had a history of contact with a dog since the past 6 months.
Okay.
And the lack of systemic symptoms or any other positive findings.
Right.
I consider a hemangioma of the liver and a hepatic adenoma, again because of the vague abdominal symptoms and the mass, and considering her epidemiology, that is, she's a middle-aged female in the reproductive age group.
Okay. How long, I mean, how frequently are these two palpable as a mass or present as a mass?
The hemangiomas and adenomas in the liver, they're usually asymptomatic lesions. They're detected incidentally on imaging. About 10 to 50% of hemangiomas are symptomatic, and they can present with vague upper abdominal pain and an abdominal mass when they are large enough.
Mm-hmm.
Even
and what about hepatic adenoma?
Yes, hepatic adenoma as well. They rarely present as masses. They usually present with vague upper abdominal pain. About 1/3 of them present with symptoms.
All right.
But the point against, but they are very well associated with history of OCP use, which is not present in this case. That's why it's a little lower in my diagnosis, even though they are very common in females.
All right. Would an age be in favor of these two diagnoses?
Yes, sir. She's in middle-aged female, sir. It's common in this age group.
All right. Yeah. What about cystic neoplasm of the pancreas?
Yes, sir. So cystic neoplasms of the pancreas are again mostly seen in females. They're mostly seen in females in the 5th to 6th decade of life. Also, they present usually with vague. They are also detected incidentally most of the time, And if they present with vague upper abdominal pain and a mass. That's
What
why
is the
I've considered-
female-male ratio, Nishan?
So cystic neoplasm in the pancreas can be serous or mucinous. A serous cystic neoplasm has a female is to male ratio of 7:3, whereas a mucinous cystic neoplasm is almost exclusively seen in females with a ratio of 10:1.
All right. Okay. What about the others? They are low down on the list, right?
Yes, sir. So I consider an amoebic liver abscess because of the symptoms of pain and upper abdominal mass. However, it's lower on my list of diagnosis because of the absence of systemic symptoms or signs. Systemic symptoms.
All right. So there is a question, I think. Dr. Shivaram?
Yes.
Dr. Abhay Dalvi has put up his hand.
Yeah, before that, Dr. Rajesh Ballard, you want to come and ask?
I put it on the box. I thought the idea of that dog in the house for 6 months was directing us towards a hydatid. Is that significant?
Well, we have to give whatever is present in the history. So, that was there, and so it was mentioned.
Yes, so considering the vague symptoms of the upper abdominal mass and the lack of any other positive history, I considered hydatid disease at the top. And that's when I went back and looked for that dog history, sir. And that's why I mentioned it.
Differential diagnosis.
Yes,
Right.
sir.
Dr. Ramakrishna is asking, can you make a clinical diagnosis of GIST?
So with the, sorry.
Yeah, go on. Nishan?
Yes, so since it was complaints of an upper abdominal mass, I went systematically with each organ. And considering she's this age group and the lack of loss of weight, loss of appetite, I've considered only mainly benign lesions. So in the stomach, I considered GIST. However, they usually also present with melena, which was absent in this case. That's why they're lower in my differentials.
All right. Sir, Dr. Abhay Dalvi, welcome
Yeah,
to you.
I just want to ask one question.
Yes.
Can you go back to the history page, please?
Yes, sir.
Upper abdominal pain localized to epigastrium. Can you name the organs which come in epigastrium?
Yes, sir. So the stomach, the pancreas, the left lobe of the liver, then they can be the lymph nodes, they can be the aorta.
Anything else that can come in the epigastrium?
The transverse colon.
Very good. So you have got these things. Then why have you shifted to only left lobe of liver or the pancreas?
Yes,
It's
sir.
a very short history, 10
Yes,
days
sir.
and then 3 days.
Yes, sir.
Distension of upper abdomen. Which
Yes, sir.
of these conditions you have listed in provisional diagnosis which gives rise to distension of abdomen?
Yes, sir. So after she because of the pain, she visited her local general practice.
Let's go to provisional diagnosis.
Yes, sir.
Hydatid cyst of liver. Why should it give rise to distension of abdomen?
Yes, sir. So after she visited her GP for these complaints, she was told there was a mass in the upper abdomen.
Correct. So now she has realized that there is mass in the upper abdomen.
Yes, sir.
How does hydatid cyst of liver mass give rise to the symptoms that she has? Short symptoms.
Yes, so there could be vague abdominal pain because of stretching of the
No,
liver
not
capsule.
pain.
Yes,
Distension. I'm still on distension.
okay.
Oh, was it distension or feeling of fullness?
It is
No,
more
he has written distension.
Yeah, I think the patient said feeling of fullness in the upper abdomen. Sort of, something sitting in the upper abdomen.
Sir, I agree with it, because the rest of the diagnosis also have to explain the distension of upper abdomen. He has to explain There are too many diagnoses which he has given.
I think
So
he has
why he has
considered.
not targeted the stomach as the primary thing, which is either compressed from outside, giving rise to distension, or something going on in the stomach, giving rise to distension? That is what he has to explain.
Yes, sir. So I did consider a stomach pathology, but it went lower down in my list of differentials because of the absence of any bowel symptoms. There was no history of early satiety. There was no history of melena or hematemesis. So
It lets me take you to what are the symptoms of CA stomach. How does it present?
they usually have history of loss of weight or appetite, so they can present.
Absolutely.
Yes, so they can have features of anemia. They can, because of.
Yeah, go ahead.
Yes, sir. And if the mass is larger, they can present with symptoms of early satiety. They can have abdominal distension as well, upper abdominal distension.
There are 5 presenting symptoms of CA stomach.
Yes, sir.
One is lump. Second is
pain,
obstruction.
Third,
yeah. So there are 5. The last one is anorexia, asthenia, and correct, weight loss. So why it doesn't fit in your diagnosis?
Because she has none of these symptoms, sir. She only had the complaints of the lump and the vague abdominal pain. There was no history of loss of weight or appetite. There was no asthenia, no anorexia. There was no.
I agree with you.
Yes, sir.
Now, in this context, GIST is the one which fits in.
Yes, sir.
Now, why did you think hydrated cyst of liver because of contact with dog?
Yes, sir. I put that higher because of the contact with the dog.
How long was the contact with the dog?
In her household right now, she's had a dog for 6 months, but she works as a housemaid and she visits multiple houses for the past many years, where she has come in contact with dogs as well.
Tell me, how does hydrated get into the picture here? What is the history of hydrated disease that reaches the liver and then causes problems, giving rise to such short symptoms?
Yes, it's usually a longer duration of history.
Correct. Shivaram sir, I think you should take over because he is wrongly directed.
Thank you, sir. Thank you, sir. There are a lot of other questions. I think actually he should have told the epigastric fullness, but I think he put it as distension. That's right, Sreevathsa?
Yeah, correct.
Okay. So 6 months history of exposure to dog, that's okay. 10 days duration of pain and mass, possibility of asymptomatic abdominal masses. Dr. Gurshantapa, you want to comment or shall we move on?
Sir, can I?
Sir, please.
Yeah, Shivaram, you can move on. We can move on.
Dr. Santosh.
One point. Yeah, I think the student should not be compelled to make a differential diagnosis at the end of a history alone. If it is glaringly obvious, yes. In this condition where there is only 10 days history of vague complaints, I would have left it open at this point of time without any diagnosis at all, where starting from peritis to the retroperitoneum, he is now missing the thought process of confining himself only to liver and pancreas. And probably it's a result of his examination which made him feel that there is a mass which fits in either with liver or with pancreas. So I would think that at this point of time, with 10 days history of vague abdominal complaints, we should keep an open mind rather than trying to get into a differential diagnosis. That would be the message I would like to pass.
Thank you, sir. Sreevathsa, will you move on?
Yeah, I think what he has done is has considered all the organs in the epigastric region, like liver can come into the epigastrium, the stomach, the pancreas, the retroperitoneum, So, and he has given possible diagnosis based on the age and the minimal symptoms. And then, yeah, he's rightly going to go on to the next level of examination and then come to, narrow down those differential that he has got. I think we should move on.
Sir, I think the message is not that you should keep your mind open is issue number one. Number two, I think that amoebic liver abscess, for example, obviously typical is a high-grade fever, chills and rigors. So it is what probably cannot be considered. That is what we are trying to tell, I suppose others trying to say. Acute peripancreatic fluid collection, that is never made a diagnosis like that. So that is what is the indirect message, rather than,
Yeah, he is going to eliminate that at the next level.
No, that cannot be put in the that's diagnosis.
Okay, fine.
Shall I continue, sir?
Yeah.
Coming to general physical examination, she's a middle-aged female, moderately built and nourished with a BMI of 23.81 kg per meter square. There is no pallor, icterus, pedal edema, cyanosis, clubbing, or generalized lymphadenopathy. Vitals, her pulse rate is 84 beats per minute, with a blood pressure of 128/84 millimeters of mercury, a respiratory rate of 16 cycles per minute, a temperature afebrile. Coming to the examination of the neck, she had a diffuse bilobar enlargement with the right lobe measuring 5 into 6 centimeters and a left lobe measuring 6 into 6 centimeters. Swelling moves with deglutition, is non-tender, uniformly firm in consistency with a granular surface. Borders are well made out. There is no bruit, no cervical lymphadenopathy. Trachea central. Carotid pulsations are felt in the normal position.
So what did you suspect, in the examination of the thyroid? You can say the diagnosis here about the thyroid.
Yes, so she has a history of hypothyroidism since 12 years, for which she was taking medication. And on examination, the diffuse bilobar enlargement, almost uniform enlargement, the gland was firm in consistency with the granular surface. And considering that she's a female, I would think it's a Hashimoto's.
Okay. Or a diffuse enlargement. Okay.
Yes, a diffuse.
Simple.
Coming to per abdomen examination, on inspection, there was no distension. The umbilicus is central and inverted. All quadrants move equally with respiration. A fullness is noted in the epigastric region. An infra-umbilical tubectomy scar is noted, which is healed by primary intention. There is no dilated veins or sinuses, no visible gastric peristalsis. Flanks are not full. On palpation, a solitary, mildly tender mass measuring 9 into 12 centimeters in the greatest vertical and horizontal dimension is present in the epigastrium. It extends 9 centimeters below the xiphisternum and 3.5 centimeters medial to the mid-clavicular lines on either side. The surface is smooth with well-defined rounded inferior borders. Fingers could not be insinuated below the costal margin. The mass is uniformly firm in consistency and moves with respiration. There is restricted mobility in the transverse axis. On placing the patient in left lateral position, the mass shifts slightly in position. Plane of the swelling is intra-abdominal and likely intraperitoneal. There is no splenomegaly. On percussion, a dull note is heard over the mass, which is continuous with the liver dullness. A tympanic note is heard over the rest of the abdomen. There is no evidence of free fluid. The liver dullness extends from the right fifth intercostal space to the right subcostal margin in the right midclavicular line. The liver span is 13 centimeters. On auscultation, there is no bruit heard and bowel sounds are heard. Per vaginal and per rectal examination were normal. Systemic examination, respiratory system, normal vesicular breath sounds were heard. There were no added sounds. There was no intercostal tendons. Other systems were normal.
Okay. There is a question from Dr. Rajgopal Shanai about the surface of the thyroid that you felt. So can you call it granular? Would you call it a smooth or granular surface of the bilobar enlargement of thyroid?
Yes, it's a granular surface. Not.
Okay. So granular surface, according to Dr. Rajgopal, is not described. It's either smooth or irregular or nodular or bossylated. So you can call it a smooth surface and say simple goiter and
goiter.
Hashimoto's.
Yes, sir. So this is my differential diagnosis after examination. Again, at the top, I've considered a hydatid cyst of the liver, a hepatic adenoma, a hemangioma of the liver, or a cystic neoplasm of the pancreas.
Why did you say there is no splenomegaly? Any particular reason?
Sorry, sir?
You said there is no splenomegaly.
Yes, sir.
Why did you mention? For any particular reason?
No, sir, it was to complete the examination. But as well,
then to complete the examination, you can also tell there is no kidney enlargement, there is no all those things.
Yes, sir. So also, because it is an upper abdominal mass, I had also lower down in my list, I considered a retroperitoneal lymph node enlargement. So keeping that in my head, maybe a lymphoma or something, I had also checked for splenomegaly.
Sorry, you're the gentleman who said that you cannot insinuate your fingers between the mass and the costal margin.
Yes, sir.
And the mass dullness is continuous with the liver dullness.
Yes, sir.
Then I don't think you should get in retroperitoneal nodes.
Yes, sir.
Clinically, that is liver. So I'd put a question in the question box. Could the liver and the thyroid be associated with each other? As a question at this stage.
The liver and not sure, sir.
The only thing which comes to my mind is
if it's
hepatitis, autoimmune hepatitis, but you won't get this big enlargement of the liver.
If we're considering Hashimoto's as the diagnosis, other autoimmune conditions.
Otherwise, I don't think there is any other connection, Dr. Balai. Rajesh, you have anything to...
Like he said, sir, if you're talking of hypothyroid in a middle-aged lady, you're thinking of Hashimoto's or autoimmune thyroiditis. The same thing can involve the reticular endothelial system. So at this stage, I was wondering whether you need to consider something like that, sir.
Okay. Okay, he has given his, he has narrowed the differential diagnosis now. It's still got... Now, would you still keep cystic neoplasm on the pancreas on the list? You said this is liver.
Yes, so since it's a mass that moves respiration, the liver, it's on percussion, the dullness is continuous with the liver dullness, and that it falls forward while placing the patient in left lateral position. I considered it more towards a liver pathology, and that you can't insinuate your fingers below the costal margin. However, a large cystic neoplasm of the pancreas, if it's in contact with the diaphragm, can still move with respiration. So I've kept it lower down on my...
Dr. Gurushantappa, yeah, come in, please.
Sir, good evening, sir. Yeah, good evening, sir. Sir, with his findings, he has a neck swelling, looks like a thyroid swelling, anatomically and clinically, and he has an abdominal mass. Anatomical diagnosis we could not hear. We'll take it as a liver mass.
Yes.
These are the two findings we have clinically in this case. So he should start with a discussion of a patient, 40 years female, hypothyroid on treatment with a thyroid swelling and a liver mass. So these 2 points he should take into consideration and try to have some pathological diagnosis at this level. So, doctor, anything can you think of, like Rajesh, which we asked, if a patient has something in the neck and something in the abdomen, if you want to correlate both of them in a given case, otherwise the patient is absolutely asymptomatic.
Minimal symptoms, rather.
Yeah, minimum symptoms. And clinically putting Hashimoto's thyroiditis for a thyroid swelling, probably it is not acceptable in the clinical examination because Hashimoto's thyroiditis is a pathological diagnosis. after doing FNEC.
You can consider. She has hypothyroidism.
Putting straight away as Hashimoto's probably looks little, that are fine. Maybe the cause is Hashimoto's, but can you think something where thyroid swelling and liver mass in a 40 years middle-aged female? Some disease?
Okay, I think you'll have to give him a clue as to what he should be thinking.
If this lady has associated lymph nodes, somewhere 2-3 lymph nodes in the neck examination, or axilla, there are 2-3 nodes. Can you think of some diagnosis?
With the thyroid swelling, sir?
Yeah, thyroid swelling, these are fixed. We have palpated thyroid swelling and liver mass. And in a general physical examination, you have found out on either side 1 or 2 lymph nodes in the axilla.
No, I think you should discuss about this case.
Rarely there can be a lymphoma of the thyroid gland as well.
Okay, sir. Sreevathsa, sir.
Yeah, I think
it's not lymphoma of the thyroid.
Exactly.
Lymphoma,
exactly.
Sorry, sir.
Exactly. Common disease involving 2 organs. That's what I wanted him to think of.
Sure.
Thank you, sir.
It's important that he has to connect what is found on a clinical examination if he can. So since he found that it was a smooth surface and she had hypothyroidism, he considered.
Dr. Gurshantappa, you can suggest him. Anything in your mind?
Yes, sir. Yes.
He said lymphoma.
Yeah, that's what I felt. So, lymphoma involving both organs.
So with this
possibility.
Swelling of the thyroid and generalized lymphadenopathy and liver considered lymphoma of the thyroid.
No, not generalized lymphadenitis. This patient doesn't have. So, thyroid swelling and the liver mass keep a possibility of lymphoma. Both organs can get involved.
Without the presence of lymph nodes.
Yes, sir.
Definitely. NHL can have visceral involvement, disease, organ involvement, NHL. Definitely can keep a possibility.
In fact, if the thyroid had been irregular, I would have, because medullary carcinoma thyroid is the only thing that can metastatize to the liver. But unfortunately, in this patient, this thyroid is smooth and it is diffuse enlargement, unlike medullary CA.
Dr. Abhay?
Sir, just one question. Let us leave the liver and the thyroid aside. If these were aside and there were no symptoms, what would be this boy's diagnosis?
I'm sorry, sir. If there was no...
Let's leave the liver aside and let's leave the thyroid aside. What would be your diagnosis?
You have a thyroid enlargement, you have a mass in the epigastric.
No, let's say we don't have all these. We have only
mass
these
abdomen.
symptoms.
Only with symptoms of vague upper abdominal pain, which...
Correct. Short-lived abdominal pain and 3 days of history.
Yes, sir. 3 days of history. It was localized epigastrium. It aggravated on food intake. I would consider something like peptic ulcer disease, sir.
Very good. Now tell me what peptic ulcer disease gives rise to these symptoms in a short time.
Sir, let us not deviate from this case.
Okay, sir. Then I have no problem. No problem. No problem.
Jagannath
No problem.
Yes,
No problem.
But at the start, with the complaints of the pain, I considered the peptic ulcer disease, sir, but the lack of periodicity and with the mass,
the mass abdomen.
All right, Nishan.
Yes, go ahead.
Dikshit, you have to unmute. You have something to contribute?
Sir, good evening.
Good evening.
Sir, I'm Jagannath Dikshit here. Sir, actually, thyroid is a...
You're not heard.
In population, I think it can be
Jagannath,
two different entities where...
Yeah, please go on.
One of the findings which has been seen through the...
Yeah, I think that was asymptomatic and examination findings. So let us move on. Next, Dr. Rajgopal Shanai, you have a question.
I just wanted to tell the student that please remember common things are common. So out of 10 women we see in the outpatient department, 1 or 2 have incidental thyroid swelling, and everyone knows about that. Incidental mass and thyroid nodule, etc. Here is a patient was so many people are taking hypothyroid for this Eltroxin tablets and whatever Thyronorm, etc. So in this patient, if the question is asked, looks like it is a thyroid is a incidental finding. She has never complained to you, asymptomatic. It very well goes for hypothyroidism in whatever we call it as. You have said granular or whatever, I consider it as almost smooth or mildly irregular. So then comes only the abdominal mass in the discussion. But if the question is asked to you, if you want to correlate, then only you start discussing on two separate masses or one separate mass or metastasis and all that, whatever it is. That's all. So thank you.
Right. Dr. Who else? Anybody has any questions?
Sir.
Okay, move on.
Yes,
Okay,
sir.
Sreevathsa?
Yeah, he can move on. I mean, unless somebody wants to. He has narrowed
we are-
down the diagnosis now, and he has confined himself to the liver.
Sir, I have a serious problem here. See this, all of us being clinicians, we are only looking at a clinical diagnosis. We are not looking at the liver function test or other tests right now. How many of us will make a clinical diagnosis of a autoimmune hepatitis? It is not clinically entertainable. It comes later on. And as Dr. Rajagopal Shenoy has rightly said, an innocuous thyroid has to be left alone.
Yes.
You should just pass it off. And then you concentrate on a liver. I mean, to me, I have never seen a massive hepatomegaly presenting as, autoimmune hepatitis. It's a pathological diagnosis when you exclude everything. So I don't think it's justifiable to make a clinical diagnosis of an autoimmune liver disease. It's a mass lesion.
Agreed, sir. Point taken. The question was raised, relationship between the two. I think he took that as a challenge and answered the question. That's it. I mean, clinically, no. Yes. Clinically, the thyroid is different.
Clinically, no.
Yes.
Right. Go on, Nishan.
Coming to the investigations, her complete blood count was normal with a HP of 11.8, PCV of 35%. Her total counts were 10,800 and a platelet count of 1,54,000. Her liver function tests, she had a total bilirubin of 0.7 milligram per deciliter, a direct bilirubin of 0.2, serum albumin of 3.2, total protein of 6.4, AST was 32 units per liter, ALT was 26, alkaline phosphatase was 46, and GGT was 12. Coming to the imaging.
Normal.
Yes, sir. Coming to the sorry,
go on.
Coming to the imaging, first an ultrasound abdomen and pelvis was done, which revealed a large anechoic multiloculated cystic lesion in the left lobe of the liver, measuring 16 into 10 into 15 centimeters. It had smooth, thick, uniform internal septations. There were no other solid components or mural nodules noted. There was minimal ascites.
So what was the suspicion at this point in time?
Yes, sir. So with the multiloculated cystic lesion in the liver, first considered a hydatid cyst.
Okay. Anything else?
It could be an atypical simple cyst or
what is atypical simple cyst? What is atypical?
A simple cyst is usually a unilocular anechoic lesion. However, if there is intercystic hemorrhage or if it's been previously treated by sclerotherapy, it shows atypical features and it can appear multiloculated.
All right. Anything else?
A cystic neoplasm of the liver.
Okay.
A cystadenomas.
Okay.
These are also.
Okay. Any questions on this?
No, Dr. Vinay Prabhu is there.
Vinay Prabhu can give his comments.
Good evening, everybody. Thank you for having me here. So what we have here on the ultrasound is an anechoic, predominantly, without any internal echoes except for these few well-defined septae. So I think from the approach to the diagnosis, the presence of any echoes within the cystic structure needs to be evaluated, whether there's a certain pattern to the septae. Are there any cysts within cysts, or are these just linear septae, or are they fibrinous strands, like cobwebbing when there's hemorrhage into a lesion? So as far as this lesion goes, we don't see any mural nodularity or any septal nodularity. So I wouldn't want to reveal a differential straight away, but the pattern that we're looking at here is a well-defined cyst with septae.
So you can't give a diagnosis of hydatid cyst or any.
Yes. So now when we look at the pattern of the internal septae, if we see clear-cut spherical cysts within the cyst, then we can immediately consider the possibility of a hydatid. So an uncomplicated hydatid cyst, we would see multiple other varying sized spherical cysts, which are also thin-walled and don't contain any echoes within those subcysts. So then that would be a straightforward diagnosis of an uncomplicated live hydatid cyst. But that is not the case here. Here we see thickish septae, uniformly thick, but each of these septae have slightly different thicknesses. So it doesn't fit into a pattern of hydatid, and these cysts are not fibrinous cysts. So like Nishan had said earlier, possibility of atypical simple cyst. So I would refine that word atypical simple cyst into a complicated simple cyst. So it is not likely to be a complicated simple cyst because the septae are too thick. So whenever there is infection or hemorrhage within a pre-existing cyst, we would expect, that cobwebby sort of fibrinous stranding, and those generally tend to move passively when the patient is jogged or shaken. The internal cobwebbing tends to jiggle a little bit like a gelatinous consistency, but that is also unlikely here. These are quite thick. So the complicated simple cyst would be ruled out. So we think of any other pre-existing cyst that could be complicated, and one is, again, we're back to the hydatid. So where the hydatid has had some form of infection, or it has ruptured, or there has been a bleed into it, or sometimes we see inadvertently sclerotherapy, or even sometimes pigtail catheters have been put into hydatid cysts and then present to us with a cystic lesion which is not typical of a hydatid, turns out to be a hydatid later. So I would still keep that possibility. Sometimes the history might not be very reliable. Patient might not disclose some longer standing history or the presence of some intervention elsewhere. So
Thank you.
Rajiv, any comments by Rajiv?
Thank you, sir. I think
Dr. Rajiv Lochan is a liver specialist, liver surgeon, transplant surgeon.
HPB,
yeah.
Thank you, sir. Thank you, sir. And the student of most of the seniors here. So it's an honor to speak at this CPC. I think I just want to make one or two brief points. I think the first thing is that, I think most liver masses are asymptomatic. I think that we should give it to the young presenter that most liver masses can grow to large sizes and they are not noticeable by the patient for notice, like some other vague symptom. And then, that symptom might or might not be connected to the mass. And then they go to a doctor or somebody, or maybe an annual screen, and then up. But of course, he should bear in mind various other organs which can exist varieties to the retroperitoneum. That's important. I think the most important thing here is that there is a mass, and most of the investigations are very benign. The initial investigations which he presented, I think at examination we have concluded that it's mostly mass. Most of the investigations are benign. And then there's an ultrasound which shows a complex cystic lesion in the liver. So I think we've thought about hydatid cyst, which is a reasonable thing in our area of the world. And then we're also, I think, thinking about some other complex cystic masses of the liver in which a cystadenoma, high up. So it's the difference between a, hydatid cyst, complicated or uncomplicated, versus a cystic neoplasm of the liver in which a cystadenoma, biliary or otherwise. I think that's where we are, and that's sort of fair enough, I think, at this stage. Thank you.
Dr. Sachin has made a comment. Can you come in, Sachin?
Dr. Sachin is there? Okay. We'll move
Okay,
on.
fine.
Sreevathsa.
Yeah, fine. We can move on.
Next, an MRI was done, which showed a large, well-defined multiloculated cyst involving the left lobe of the liver with a size of 10.9 into 12.3 into 15 centimeters with a volume of 1005 cc. An anterior exophytic component is seen with no ductal communication.
Dr. Vinay is there. I think he may be.
Yeah, we'll play this.
So this is the T2 weighted MRI showing hypertensity. It shows a well-defined multiloculated mass.
Yeah, put up the still image, please. T2 weighted. Yeah,
This is the T2 weighted image showing a multiloculated mass with septations.
Okay, any takers on this image? Anybody from the delegates and the invitees and guests, any takers on the diagnosis? Vinay, can you come in?
Yes, sir. So here we have a non-contrast MRI, and so what we have here is the T2 weighted image, and
Yeah, you are muted, Vinay.
Vinay, we are not able to hear you.
Can you hear me now?
Yeah.
Okay, let me repeat. So on this T2 weighted MRI, fluid appears bright and the cysts appear intermediate in signal. So we see pretty much what we saw in the ultrasound, which is a well-defined large cyst with septae. So here we have a little better understanding of the pattern and arrangement of the septae. Again, here they are almost somewhat uniformly thick, no nodules in the cyst, in the septae, but we don't see typical spherical loculi within the main cyst. So again here, so to differentiate between say a biliary cystadenoma and a complicated hydatid cyst, we should see a lot more layering within the cyst if there has been previous infection or hemorrhage, which we're not seeing. There's a little bit of heterogeneity to the intensity, so that can be seen in biliary cystadenomas, also in hydatids. So depending again on the quantum of hemorrhage that might have happened into the lesion, those intracystic variations may be possible. But looking at the pattern here of the septae, I think we can almost certainly exclude hydatid. So we're back to the possibility of a biliary cystadenoma.
Okay. Nishan, can you go on?
Yes, sir.
Or are there any questions?
Nishan, 1 minute. Dr. Prabal Niyogi is there. Welcome, sir. Vice President of ASI. Dr. Prabal, you can unmute. Okay, maybe he's busy. All right,
Okay.
Dr. Rajgopal Shenoy, you want to make some comment?
I think I have already put, looks like, that hydatid cyst is less likely. There's also looking at that typical cartwheel pattern or even some kind of movements they can see actually during the floating, all this, daughter cyst and other things, less likely. That's what I have put. And women, and he has mentioned about oral contraceptive pills in the somewhere in the history, all that, looking at that, probably benign nature with the hemoglobin, everything is normal. So something like adenoma, that's what is likely. That's what I've said. That's all.
So you would not, take hydidicist out of the picture still. Okay. Because if he doesn't say hydidicist, people will jump at him. And
again, sir, we always tell that because endemic area and a parasitic disease in Indian scenario, whether dog contact is there or not, it is not the idea. When there is a benign liver mass, we have to consider as a clinical
multisepte.
Definitely.
Okay.
Dr. Rajiv, see, when you have an ultrasound like this, what is your protocol to proceed further?
So thank
protocol and just to understand better. That's all.
So so what we would do, and is in this type of situation, where you have a liver lesion, which is a complex liver lesion, probably cystic, probably solid, there are some solid components within a cystic lesion. We're really not sure. I would prefer a triple phase CT scan. You should actually call it a 4-phase, because even the plain scan is actually not. So you need a plain scan, arterial, portal, and venous phase scan of the liver and the pancreas without oral contrast. We do not use oral contrast. There's a lot of people who give oral contrast, and sometimes we do need oral contrast. We would use negative contrast, basically give water. So that's what we would do. That is the standard scan. That's a standard imaging modality in any HPB, mass lesion. I think that is the beginning, and that is what I would do. It's simple, and the protocol is straightforward. And I think we as surgeons, we can understand it much better. You can reformat it, axial, coronal, sagittal, various views. And it's not as complicated as an MRI. As an MRI, you would need the assistance. So we would do a CT first, sir, and then think of other things.
Right.
Can we proceed there?
Yeah.
Can we proceed?
Proceed.
Yes, sir. So with the above imaging, after it was done, we went ahead and did a diagnostic laparoscopy. Intraoperatively, a multiseptated seromucinous cyst was noted involving the left lobe of the liver, that is the whole of segment 4 and segment 3 partially. Around 800 ml of straw-colored seromucoid fluid was drained. The septae were thick and vascular, and the right margin of the cyst extends up to the gallbladder fossa. This is an image of the cyst showing a thick
see the
wall.
blood vessels.
Yes, sir. There was vascularity on the wall as well as the bluish tinge. So these findings took us away from a diagnosis of a hydatid cyst.
And also the fact that we had encountered a case like this 2 months ago.
Yes, sir. Then a laparoscopic marsupialization of the cyst was done. This is a short video of the... So this shows the extent of the liver cyst. This is the left lateral lobe of the liver. The right margin extends up to the gallbladder fossa. The thick cyst wall with a bluish tinge showing vascularity. After the cyst wall was opened, we noticed that it was multiloculated with mucoid fluid, and within the cyst there were multiple smaller cysts, each filled with mucoid fluid. You can see the multiple smaller cysts and the mucoid material.
Okay, proceed.
So with these findings, intraoperatively, we consider the diagnosis of a mucinous cystadenoma at the top and the possibility of an intraductal papillary neoplasm of the bile duct. But it was unlikely due to the absence of bilious fluid as these tumors usually have a communication with the bile duct.
We're talking about the second one having.
Yes, sir, the second diagnosis, sir. These were our two diagnoses intraoperatively, but due to the lack of bile stain fluid and intraocular papillary neoplasm was lowered up.
And also imaging did not show communication with the bile
Yes,
duct or bile duct dilatation.
Yes, sir.
But if you have intraoperatively, if you think like this, these two differential diagnoses, will you do a marsupialization?
I think what was done was to send a specimen for histopathology. It was not at a therapeutic measure because he can't answer the question, so I'm answering. So the frozen section doesn't give you a definitive diagnosis. So in a situation of a mucinous acidinoma or papillary neoplasm in the bile duct, a frozen section doesn't differentiate between the two, and also it cannot rule out malignancy. If there is some change in some part of the wall of the cyst, malignancy cannot be excluded. So the final diagnosis rests on paraffin section.
Okay, I think can we let?
Yeah, we can ask Dr. Mangala.
Dr. Mangala, come in.
Yes, sir. Sir, small cystic neoplasms, maybe we could tackle it with our frozen section. But if it is too large and there are varied changes, then it probably is risky. But maybe we can do multiple samples. But finally, we put a note saying that please await paraffin sections for the final diagnosis.
Right, next, Nishan.
Yes, sir. So the cyst wall was sent for histopathology, which showed features consistent with a benign mucinous cyst adenoma. Post-operatively, a CEA and CA 19-9 was sent, which were within normal limits. With the diagnosis of a benign mucinous cyst adenoma, we went back for a definitive treatment. So the patient underwent a left hemihepatectomy, and intraoperatively, multiple bilioma and mucoid collections were found between the cyst and the omentum. This is an image of the left hemihepatectomy specimen. Now, coming
any
to the
questions at this point?
Sir, Venkat here, sir. Good evening.
Hepatectomy was done the entire laparoscopically?
No,
it was an open hepatectomy, sir. It was done a week later after the initial operation.
Dr.
Good evening,
Venkat.
sir.
Venkat.
I think from the beginning, I was seeing the mass fullness in the upper abdomen, cannot able to get up above the level of the swelling. It was more like a liver mass. But as Dr. Raju told, only MRI was done. I didn't see any CT images. But this, once you saw mucoid material going out, I think it should have been resected at the same time, because these mucinous materials, deposits on the peritoneum, pseudomyxoma, later on they may recur and trouble the patients. So generally, then the mucinous tumors, we should try to avoid spillage, keep it as little as possible. If it has already happened, okay. But once the mucinous material started flowing, like Dr. Rajgopal Shanai, Dr. Gurushant, everybody were telling, it didn't look like idiated cyst. I am out of the idiated cyst for a long time, but probably we could have resected it at the same time.
Without taking consent for a major surgery.
Yeah, that is when it should have been taken. Consent should have been taken beforehand itself.
Well,
there is a necessity of resection.
We did
correct.
have.
I understand.
That in our mind.
This is not a usual situation, but once when we plan, initially itself, it should have thought of it. Consent should have been taken, if necessary, a liver resection.
This condition is so rare. It is right. Probably 250 to 500 cases might have been reported. So
what happens here is, sir, what the spillage of the mucinous material, whatever spillage happened, that is what is going to trouble later. That is not the resection. Resection, right? They would have removed everything.
If malignant.
Even benign also, mucinous material spilling, Pseudomyxoma is not malignant, it is benign. Later on, recurrent, it can become malignant. But initially it is benign. Mucinous implants, mucinous cells implanting on the peritoneal surface.
Dr. Rajiv, what is the current indication for the marsupialization?
Sir,
always resection.
Yeah, sir. I mean, the only place where we would do a marsupialization is, when you have a very large, simple cyst, which you're not able to, resect, and it becomes too difficult. It causes a tedious or long procedure, and this large, simple cyst is causing symptoms, and we are having to do something about it. So in fact, I've tried percutaneous aspiration a few times as well, and then you do if you end up, but these things do recur. So the best thing is you do a laparoscopic marsupialization of a simple cyst, and then because you empty all the fluid out, and you're absolutely certain, like Dr. Venkat was saying, that it is just fluid and it's not going to really trouble the patient. That's where I would do marsupialization. That's about it, I would think. I think here the point was that they were trying to take a sample for histopathology. Maybe they didn't want to really marsupialize. Maybe I haven't done marsupialization in a very long while.
Yes.
Right.
But I agree with what that was saying. Is that no? I think that if we are going to go into surgery for a complex cystic lesion of the liver, apart from echinococcus and the cystadenoma, either biliary or mucinous, we don't have that many options really. And I think we should be prepared for a liver resection. I mean, that's my feeling. But unfortunately, even if we send a sample, I mean, we've seen lots of recurrent biliary cystodermas which come back. They can be reported as a cyst with columnar lining, and here, because it's a teaching hospital, they were very aware. They went in and operated second time. But we've seen lots of such patients operated on elsewhere, coming back with a mass which is 5 times larger than what initially was the case, because it was reported as a cyst with a simple lining, and the patient came for follow-up a couple of times and then didn't bother. But it was actually a biliary or a mucinous cystadenoma. I mean, mucinous cystademas are not that very uncommon. We do see quite a lot of them.
Nishan, carry on.
Yes, sir.
You have anything more?
Yes, and now coming to the histopathology discussion by Dr. Mangala.
Yes, madam.
Can you go on to the
Madam, you have to unmute. Madam, yeah, right.
Can you hear me, sir?
Yes, yes.
Can you go on to microscopy, please?
Madam has to unmute.
Can you hear me, sir?
Yes, yes.
Yeah. Sir, actually, we received cyst wall with focally ulcerated area with no definite lining, and there was adjacent hepatic tissue with congested vessels. We also found numerous pigment-laden multinucleated giant cells, which also tells us the tale that it could be a focal hemorrhage in the cyst previously, telltale story of a focal hemorrhage within the cyst. However, we never found any atypia or any dysplastic changes or malignancy in the sections what we had elaborately sampled. So this is the scanner view showing absolutely sort of ulcerated lining. I mean, we didn't have any lining itself, and this was the cyst wall with foci of hemorrhage. And here we are seeing the liver tissue showing hepatocytes, sort of a little ballooning degeneration and sort of reactive changes seen. Here we are seeing giant cells. We found a few giant cells. These are the giant cells and the sort of edematous scattered hepatocytes. Here also we are finding giant cells with sort of hemosiderin-laden pigment within them, and mild lymphocytic infiltrate. These are the lymphocytes which we found in these sections. Otherwise, there was no evidence of any dysplastic changes or any malignancy-related changes. And other areas, we found a little sort of fibrotic areas with congested vessels. Coming to the actual cyst wall, we found that there was a single layer of lining of ciliated columnar cells. The same thing in the higher part, we can see there are single layered cells. Nowhere there was any stratification or dysplasia. And carefully, if you observe the stroma, it is like the ovarian-like stroma which we found. So that is one of the commonest things what we find in these type of cystadenomas in the liver. So compactly we can see, if you don't tell me the history, I would probably call it as an ovarian stroma. So that is how it is. So this is the ovarian-like stroma. The actual lining is well appreciated here as a single layer of columnar epithelium with basally aligned nuclei. The same thing under high power, we can see that the nuclei are beautifully basally aligned, and we can see the apical mucin-like things in the collections. And this is the ovarian-like stroma. And this is this actual cyst wall, contents of the cyst wall, we can say here. The same thing here. So actually, these are the spindle-shaped cells which are tightly clustered with some congested vessels in between. So this is that fibrostroma or the ovarian-like fibrostroma, which is very, very characteristic of the cystadenomas of the liver. Next. In between, we also could find some cystically dilated glands which are akin to the biliary ducts, dilated biliary ducts and acini. So these were the ones. Again, here we never found any. We tried to sample plenty of tissue and never we found any stratification. Everywhere it was just a single line, and these were the dilated glands and bile ducts within the stroma, scattered amidst the stroma. In fact, we heavily hunted for any dysplasia. And this is the ovarian-like stroma showing congestion, part of congested vessels. And again, we also found a small tissue hanging to this cyst wall. We also sampled that, and that turned out to be just the fibrofatty tissue, which we can see here. So for our final impression was mucinous cystic neoplasm with secondary reactive changes in view of the hemosiderin-laden macrophages, giant cells, and the hemosiderin areas. So we just called it as a mucinous cystic neoplasm, probably benign with secondary reactive changes. And all the margins were uninvolved and unremarkable. Gallbladder, which they had sent, showed acute and chronic cholecystitis. And omentum, which they had sent separately, tend to show some chalky areas in between. So we had a doubt. So we sampled those areas plentifully. And all we found was fat necrosis and lobular paniculitis. It is just a part of an inflammatory story. So there was no evidence of malignancy, no evidence of even dysplasia anywhere in the extensively sampled sections.
Yes, sir. So this was an image of the patient at 3 months follow-up. Shall I move on to the discussion, sir?
Yeah, quickly, please.
Yes, coming to the discussion. So neoplastic liver cysts usually affect females in the 4th to 5th decade of life. Their etiology is unknown. However, they're postulated to arise from embryonic ovarian cell rests. They usually present as large lesions causing symptoms, and approximately 10% of them are malignant. However, this percentage has been widely, it's very different according to sources. It varies from around 5 to 10%. And a definitive diagnosis is obtained by an intraoperative biopsy of the cyst wall. So there are two forms. There can be a mucinous cystadenoma or an intraductal papillary mucinous neoplasm of the bile duct. So they have a prevalence of less than 5% of all intrahepatic cysts with an incidence of 1 in 1 lakh. There are two types with mesenchymal ovarian-like stroma, which is currently a WHO criterion for the diagnosis of a mucinous cystadenoma. They occur only in young and middle-aged females and have a low potential for malignant transformation. However, the second type is those without a mesenchymal stroma. They are currently, the current nomenclature is an IPMNB, that is an intraductal papillary mucinous neoplasm of the bile duct. As compared to ovarian-like mucinous cystadenoma, this is more common in males and occurs in the 5th decade of life and has a higher potential for malignant transformation. It is also frequently associated with a bile duct communication. So a comparison between the two varieties, a mucinous cystic neoplasm is usually a multilocular fluid-filled mass with smaller cysts within the cyst wall. It usually does not have a ductal communication, and an ovarian-like stroma is a criterion for its diagnosis. Usually it is estrogen and progesterone receptor positive. Whereas in contrast, an intraductal papillary neoplasm of the bile duct is a multicystic lesion with a grape-like appearance. They can have mural nodules, peripheral calcification, eggshell calcifications, and enhancement of the cyst wall with a bile duct communication. The stroma, however, in comparison is fibrous. The mucinous cystic neoplasm in the liver expresses mucin 5AC and is also cytokeratin 7 positive, which is not seen in the IPMNB. Also, malignant potential is higher in an IPMNB. Coming to the pathology, they're usually slow-growing multiloculated septated tumors which contain bilious or mucinous fluid. The presence of bilious fluid should alert to the presence of a ductal communication and the likely possibility that it is an IPMNB. It's usually lined by columnar epithelium with papillary projections. There are certain features which should alert us to the fact that it could be a malignancy, such as the presence of hemorrhagic cyst fluid, the presence of papillary projections or mural nodules in the cyst wall, and on microscopy, the presence of intestinal metaplasia in the lining epithelium. Presence of eggshell calcification is also a predictor of malignancy. Clinically, a majority of these lesions present asymptomatically, and if symptomatic, they present with vague upper abdominal pain and an upper abdominal mass, with complaints of fullness or bloating, and rarely can present with pressure symptoms such as jaundice or duodenal obstruction. However, this is rare because they tend to be soft tumors, and even though if they grow to a large size, they do not tend to cause compression symptoms. On investigations, on an MRI, it appears as a fluid containing well-defined loculated mass with septations, which is hyper-intense on T2 weighted images. On contrast-enhanced CT scan, a wall enhancement is noted in the contrast phase. This is an MRI showing a well-defined loculated cystic lesion. The walls show presence of calcification. It can be seen on image B. Image D shows the T2 weighted image, which shows a hyper-intense lesion, which is consistent with the diagnosis of a mucinous cystadenoma. Coming to tumor markers, this is so serum CEA and CA19-9 levels are usually normal, but they can be elevated. So they are not very reliable for a diagnosis of a mucinous cystadenoma. Even cyst fluid analysis can show elevated levels in an biliary cystadenoma. This would help if you're trying to differentiate between a simple cyst. However, otherwise it's not very helpful towards a diagnosis. Trying to obtain a percutaneous biopsy for a diagnosis prior to surgery is not recommended, as it rarely gives a diagnosis, and there's a risk of peritoneal dissemination if it is malignancy. Coming to the treatment, enucleation can be considered, that is removal of the cyst, the surrounding wall, and a rim of parenchyma. However, if any tissue is left behind, there is a 100% chance of recurrence. So a complete anatomical resection is advised. Also, additionally, due to the risk of malignant transformation, an anatomical resection is preferred. If the lesion is unresectable, then a liver transplantation can be considered. Coming to the complications, one is malignant transformation. Then the lesion can fistulization into the biliary tree, free rupture into the peritoneal cavity, superinfection, bleeding, and pleural compression. Prognosis in a biliary cyst adenoma, the 5-year survival rate is 100%, and with complete resection, there is or there's less than 10% chance of recurrence. In a cyst adenocarcinoma, however, the 5-year survival with complete resection is only 65 to 70%, and with partial resection, it falls down to 20%. These are my references. Yes, thank you.
Thank you, Dr. Nishan Shetty.
Thank you so much.
Excellent presentation. Comments by Dr. Rajiv, Dr. Venkat, Dr. Sreevathsa.
Well, I can say that Nishan has done a good job of presentation.
Thank you, sir.
There have been
Yes, sir.
some
Very good
lacunae
job.
in going through the differential diagnosis, and that is acceptable. It's covered the subject well.
Any learning
Mass
points?
abdomen, mass abdomen is always a Pandora's box. Abdomen is a Pandora's box. You don't know what can be inside. So you have to just, Dr. Dalvi sir asked one question, what are the anatomical organs located in that area? So we'll have to go based on that. And not many will put a ovarian type mucinous cyst adenoma inside a liver as the diagnosis. So you can say it's a liver mass, but you did a good job. You presented it very well, and you have compiled the data also very well. And rare tumors are always difficult to manage. It involves many group of doctors, multidisciplinary team to involve. Now, once we have the diagnosis, it's very easy. Posthumously, everybody is perfect. So nothing wrong. Only thing is we have to follow for, if at all, that small percentage of 10% or something of recurrence.
Follow up the patient.
Close follow-up has to be done at least once in 4 months in the initial 2 years, and then once in 6 months, 5 years. Then you can keep it yearly follow-up.
I think what one needs to know here is female 40, segment 4. Female 40, segment 4, multiseptate cyst. Think of cyst adenoma or cyst adenocarcinoma. If it is a male carcinoma.
Dr. Shanai.
Thank you very much. Firstly, congratulations to the presenter. He's quite bold, very clear, lucid, and well prepared. So very well done, Nishan Shetty, number one. And obviously, has been prepared by his mentors. Just want to add one comment about clinical pathological conference. As a postgraduate, I had good number of these during our time, like Dr. Shivaram said. See, remember, it is clinico pathological. The word radiological is missing there. If you try to recollect, those days it was based on only clinical grounds that colon was removed, whatever, liver was resected, pancreas was done, and it may turn out to be something else. So I know that total colectomy was done, diagnosing a ulcerative colitis for a strongyloidosis infection. So those were the times which are gone. So I'm not trying to say that this is not interesting or interesting. The reason was simple. Today, radiological imagings have made almost nearer the diagnosis. So that's why one question was asked here that triple CT, why it was not done. I am not expert in this, especially this field of liver, etc. But maybe that was one of the things would have also helped in the diagnosis. So as for the postgraduates, common things are common. Hydrated cyst definitely should be entertained when there is a liver mass. So obviously then comes the other things when the question is asked. And I think management has been explained. Postgraduates should try to correlate the investigation finding to the disease process. So that is what is required. Good discussion. Very well done. Everybody is. Thank you, Dr. Sreevathsa, for your student. Thank you.
Only one comment, sir. I mean, you were talking
Nishan,
about.
You can stop sharing, Nishan Shetty.
Yes, sir.
Yeah.
Just one comment about the imaging. We had to do MRI because the MRI was supposed to be better unless we suspected malignancy when triple phase CT would be useful, and we had to cut costs here. I told you in the beginning that she was from a low socioeconomic status, and we had to subsidize everything. So Indian conditions, we have to sometimes cut corners.
Agreed. Yeah. Anybody else? Dr. Vinay Prabhu, thank you so much for joining. Dr. Mangala Gouri, thank you very much, madam, for your.
I need to thank both of them. Thank you, Vinay and Mangala Gouri.
My pleasure, sir. You're welcome.
And thank you, Rajiv.
Good night, sir.
Thank you, sir.
Dr. Hebsur,
Good night.
any comments from you? Dr. Gurshantapa, final comments.
It was a Nishan nice presentation.
Thank you.
You were looking confident, and it was a very fluent presentation. In the clinical examination, definitely once it comes to liver mass, and if the questions are asked after that imaging which you had put, still for a postgraduate hydrated cyst and cyst adenoma, both I think probably we need to know. Even though imaging almost it was ruling out, but for a postgraduate, both the categories. Probably the questions may be asked even for the management of hydrated cyst also. So otherwise, quite a good discussion and informative. Shivaram, nicely done. Sreevathsa sir, nicely done, sir.
Thank you, sir. Thank you, sir. I
Dr.
mean, even for a surgeon, I would
there?
take both into consideration.
Yes, sir.
Yeah, you can sum up everything, I think. And also
Rajiv?
what we have learned in this case.
Yeah, I think lots of things have been told by all the seniors and teachers, and I think points have been summarized. I think it was a good history, good examination, and I think Nishant did a good job. I mean, he's in the second year of training into general surgery, and I think a systematic approach is what is needed, which is what most of the seniors have pointed out. Is absolutely fantastic. And also, like Dr. Sreevathsa sir said, we live in a real world, and I think we have to, although there are lots of algorithms and flow charts which we follow and guidelines, but I think we tailor them to the economic situation that we have. And I think the patient was definitely managed well, and the diagnosis was considered, and patient underwent definitive surgery. Nishant did a good job. And I only hope that this particular case will interest him into taking up liver surgery as his future calling, and and certainly looking at his confidence, I'm sure he'll do a very good job, at that. So thank you, Nishan, and thank you, Sreevathsa sir, for mentoring him. Thanks.
Thank you,
Shivaram sir, for.
I think Nishan has got a blessing right away.
Yes.
Yeah, thank you, Shivaram.
It was a very nice presentation. All possibilities were probed, and I'm humbled by the simplicity of all the consultants. They came down to the discussion, and it was a great forum, and I think it's a good forum. I think this should keep going so that more and more postgraduates will
benefit,
achieve better scope for learning in these areas. Thank you very much, sir. It was nice being a part of your crowd.
Thank you. We'll trouble you on and off.
Yes, sir. Thank you. Thank you so much. Nice meeting you all, sir.
Shivaram, only one small. Nothing. As per the MC and NMC, madam, this CPC is a must actually, even for the postgraduates. Postgraduates. Invariably, it is not being done for whatever be the reasons. Availability, surgeons want some time, and pathologists that time may not match. Surgeons will be in the theater and all. But it is one of the requirements if it is done.
Yes, sir. Sir, in our college, we have been doing it. And in per month, we have 11 CPCs with various departments. And every third Monday is with surgery.
Oh, good. Very good.
Yes, sir.
Rajgopal Shanai, do you have any comments on the way that this was conducted?
No, sir. It is good, sir. Only thing is I think the boy knows the diagnosis, correct?
No, he might know the diagnosis, but he can't explain it on clinical grounds, right?
No, sir, not like that. What I meant to say, sir, when we used to get the CPC done, surgeon who has operated actually has no idea about what he has done. Ultimately, pathologist will come and tell, sir, what you have done is a blunder. I'm sorry to say this point, but ultimately, pathologist will tell what you have done is wrong because this is the diagnosis.
True.
I'm very open. That's all. Thank you, sir.
Yeah. You put the nail on the head. That is true.
Correct.
That is true.
Yes.
Those are the times where we had no
Yes.
radiology support.
Correct. So it's now today.
Pathologist was the final.
Yes, yes.
Dr. Ramakrishna, you have any comments? Ramakrishna, you're there? Okay.
Yes, sir. Yes, sir. Yes, sir. I'm there.
Late into the night,
Yeah.
people have said bye.
Thank you
Sir,
so much. Yeah.
I am a practicing surgeon, especially in a rural area.
Shumoga.
So from my from not Shumoga, sir, Bhadravati. From my point of view, I think the initial diagnosis what he gave after looking at the history, it was too much imaginative, I thought. And then the rest of the things, it went on well. But the last reservation was about the marsupialization. When we are uncertain of diagnosis, I think that marsupialization should not be done, sir. That's what I felt. And you already have experts' opinion on that. So presentation was very nice, sir. Thank you.
Thank you, Ramakrishna. So, Dr. Chandru, you'll conclude?
We'll close it down, sir.
Yeah.
We'll conclude, sir. Yes, sir. On behalf of KSCASI, I thank the young surgeon, Dr. Nishan, for an excellent presentation. I also thank the moderator, Dr. Sreevathsa, sir, Dr. Mangala Gouri, Dr. Ramaiah Babu, and Dr. Rajilochan for excellent moderation and giving a lot of inputs to this clinical pathological case discussion. On behalf of KSCASI, I also thank our National Vice President, Dr. Prabal Neogi, sir, and Academic Council Director, Dr. Santosh Jan Abraham, and past President of ASI, Dr. Abhay Delvi, sir, for joining this discussion. And I also thank all the senior teachers, national and state EC members, and all the members of KSCASI who have joined in this clinical pathological case discussion. Thank you, everyone. Hope to see you for next webinar in the last week of Thursday. Thank you. Thank you, everyone. Good night.
Good night.
Good night, everybody. Thank you so much.
Thank you so much, Shivaram and Chandrashekar. Bye.
Thank you, sir. Excellent. Thank you so much.
Bye. Bye.
Your,
Thanks.
First CPC done this year. Zoom meeting.
My pleasure. My pleasure. Thank you.
Thank
you, sir.
Yeah. Thank you, Shivaram.
Thank you. Good night. Good night.